Well, good evening, everyone, and I hope you've had a great week. It's been an honor to serve the last year, and we've been very busy with a lot of activity and advocacy, as well as getting the registry up to speed and of course, building on every educational venue that we possibly can. I think we've heard a lot about overutilization over the last 6, 7, 8 years. And I want to walk you through some of the things that we've learned this year and potentially a strategy forward as we get started. So the current problems, and I think that we might have more problems than this, but I think these are the big problems that we have. You can't escape a compound annual growth rate of 15%. And if you see the rise in procedures that we've all seen, this was going to grab somebody's attention. So this ship has sailed, and we're well under the microscope right now. It doesn't mean doom and gloom, but we have to pay attention to that. Benchmarks are lacking, and we get cases like this. I was consulted to evaluate this case for standard of care. There's many places that it got missed, but bottom line, a 22-year-old female had a small saphenous thrombosis that extended barely into the popliteal, and it involved both gastrocs. This is based on a hospital ultrasound that actually was pretty good compared to most of them that I see. Why the patient was treated with just 6 weeks by a hematologist as a relative, I'm not sure. They did find that she had factor V Leiden, was never given any compression stockings, and ultimately showed up at a vein specialist visit. So the image that you see to the right is a small saphenous. There were no images to show reflux in this vessel, but the ultrasound study showed that that vessel was dilated and it was non-compressible at least at one point. So I think we can all hypothesize if you've got a thrombosis, it's likely recanalized, and it's possible that this patient's symptoms were related to reflux of the small saphenous. But the reality here is the patient had 2 access points to the small saphenous. I'll even give that some credit. If you're getting into a thrombosed vein that you're trying to ablate, most of the time you can get past it with a single access, but there's times that you just can't, and you may need to do 2 separate access points. So even given that possibility, there was no indication to two access points to the great saphenous or 2 access points to the anterior accessory saphenous, and 6 separate ablation codes were billed in this case, and this is what payers are looking at. Now, we haven't had benchmarks until recently, but this is the type of stuff that we all hear about, and this is one of those cases. So in a study looking at 21,000 limbs, just the epidemiology of an outpatient vein practice, this came from the registry, and if you look at primary reflux patterns, 73% of limbs are single vessel, 22% are 2 vessel, and 3 vessel pathology is only 5%. If you just do some simple algebra, and this actually matches Nikos's paper in the Crawford study, but simple algebra suggests 1.32 ablation procedures per limb. This is consistent, okay, and that's in two separate locations. You may be familiar with multiple investigations now giving us numbers for utilization rates. If you were to, everybody here got an Improving Wisely report? Yes, no, maybe. So Improving Wisely was an educational endeavor to try to make sure providers knew where they sat, because what you received in a report was where your ablation per patient ratio was in comparison to the aggregate, but I can tell you this came from payer data and they already knew it. What we found in each of these studies is that the median ablation rate was 1.6, 1.7, and 1.6 ablations per patient. That's pretty consistent. We have benchmarks, and that's why I think it's not so much about over-treatment now, but under-treatment as I move forward. If you dissected the Improving Wisely information by MAC, granted, these MACs have different populations, and this isn't necessarily scientific at this point, but you can see the heavy users, if you will, in the top quartile are in the Novitas distribution, Noridian, and First Coast. When you broke the top quartile down by specialty, those that did the most ablations were actually vascular surgery, general surgery, or cardiology or interventional cardiology. Now, I want us to think about this for a minute. This is not scientific, but when you think about ablation codes, some of these specialists may be doing a lot of perforator ablation. If you look at the max that these high users were in, it's pretty liberal about what you can do for perforators. So it's possible they ranked higher because they're doing a fair amount of perforator ablations versus something else. It's something at least worth noting is why they might be in the top rank. But I think we can't ignore practice variations that's driven by payer. And then we've got carrier perception. And I gave you the one case that we all know about. I mean, not the one case we all know about. We all know about these cases of people that are overtreated. But these are things that have been made very clear to us with different interactions we've had with carriers. In September, we had a peer-to-peer review where the UHC medical director said that authorizing 3 sclerotherapy sessions was no big deal. What he was really stunned with is that he recently had somebody request 45 sclerotherapy sessions. I've done sclerotherapy for a lot of years, but I think the person would have to be as tall as a ceiling in order for me to think I needed 45 sessions. Am I wrong? Does anybody here need 45 sessions of sclerotherapy to fix a leg? So this is the type of thing that gets attention, right? Now, these are quotes from medical directors sitting face to face. This cardiologist is taking patients with CHF and ablating 4 veins just for edema. The payers know what is being done. It's not a question. What they're finding, though, is that the indications for this is not necessarily so clear. Gets to the next one. And even though this is done, we can't even tell what vein is being treated. I think we all know electronic medical records can help simplify what we do, but you still have to be able to report what you do. And I think it's something that we can all improve upon if we're not doing a good job, because I can tell you they're reviewing records, and if you can't make it clear what's being treated, it really draws attention to yourself. This is a quote that actually caught me off guard. It says, there's an internist in this town doing ablations. He has no formal training and has no business treating veins. I said, well, I'm not so sure you can say that. And she says, what do you mean? I said, well, what's my primary specialty? Well, your vascular surgery, of course. I'm still boarded in emergency medicine, okay? I haven't worked in the pits for 17 years. I've pretty much dedicated the last 17 years to helping people with venous and lymphatic disorders. And I said, I've cited the literature for you. I've helped you understand the new technologies, but you thought that I was that internist for a while. If you'd have thought I was an internist, you probably wouldn't have listened to what I did, because you didn't know that. You can't assume that just because somebody's got a different background that they don't know what they're doing or that they're not qualified to treat. So I think we made some progress, because at least that particular provider actually stood back and actually recognized that, well, maybe I've got this all wrong. But she's not the only one who thinks this. So there are others out there that still have this belief. The non-thermal treatments are more expensive and the data is biased. That's actually true. Now, that doesn't mean that that can't change, but what they're wanting to see is unbiased data that may come from the registry instead of something that's coming from a corporate-sponsored study. What they do understand, though, is that our margins are the same, whether it's laser radiofrequency, MOCA, or PEM, the margins are the same when it comes to these newer technologies. The thing that was brought up, and I think we all have to be aware of, is the perception of double dipping. They see that patients are getting an ablation of the great saphenous vein, and then these newer technologies are being used for the distal great saphenous. And it's the belief that they want to pay for one technology for one vein, and at least not think about using all the most expensive things as they're treating. I'm sharing this because this is their perception, and we need to be aware of this. This is another problem. All of this finger pointing that we have of this guy's doing it differently, this guy's doing it differently, we're not helping ourselves, okay? This is something where we actually, as a society, have to work with other societies, and I believe we're well on the path of getting true alliances. And what we need to see more of is really the handshake. There are different activities we're doing with OEIS, there's different activities we're doing with the American Venous Forum, and we're trying to build a rapid response team as we see other assaults coming toward us. Recently, we've got a physician from Michigan who's a general surgeon background who is told she's no longer going to get paid for ablation because she didn't have formal training in the vein space. I think we might all argue if that can happen in Michigan with a general surgeon, it can happen anywhere. And so these are the type of things that are happening that aren't necessarily for a bright future, but I think there's opportunity. I want to talk about underutilization. I want to talk about this case for a second. How many of us here treat leg ulcers? Thank you. Despite evidence that says early intervention can help these patients, the protocol in my community, well, we're going to debride you every week. They don't use compression. They're going to debride you every week. You're going to get an ultrasound to make sure you don't have a blood clot. Now, if you're not better in 3 months, you're going to get another ultrasound. If you're not better in 3 months, you're going to get another ultrasound. If you're not better then, you get a CT venogram. And if you're still not better by a year, they send you to Schul. So they keep them in the clinic for a year before they come out to my practice, okay? There is a big conflict of interest here. So 3 ultrasounds in this patient. Does that look like a venous leg ulcer? Okay, right area, correct? You see some discoloration at the foot. You see the stasis dermatitis. On her leg, you don't see any visible varicosities, okay? So I'm telling this patient who's had 3 ultrasounds, well, you know, this could be something else, but we're going to have to take a look. So sure enough, she's got reflux from her saphenofemoral junction to the ankle. Okay, that's the superficial system, just the great saphenous. The small saphenous was normal. Much to my surprise, she's also refluxing from her proximal femoral vein all the way through the popliteal, her gastrocs, and her posterior tibials all the way to the ankle. This lady had intractable pain, had 3 ultrasounds. They never went below the knee, but they missed the chronic scar that she had in her popliteal vein. She had a 50% residual scar in the popliteal vein. No wonder she wasn't healing. She had combined superficial and deep reflux, no compression, debridement every week. If this is the standard of wound care in our country, something's got to give. But that's not just in my community, that's in other communities. So if we looked at improving wisely data and parceled out something that didn't get reported in the article, but I think was still an important investigation, we looked at the intervention rate, the number of patients that ultimately went to intervention by a percentage. And those that had pain, swelling, and inflammation, they approximated about the 40% intervention rate. Those that had venous leg ulcers, a surprising 32%. So that means they actually got to a vein clinic, okay? Got to a clinic that could fix them. Well, maybe they're post-thrombotic, maybe they've got no superficial incompetence, but they had a diagnosis, an ICD-10 diagnosis of a venous leg ulcer, and ultimately didn't get an intervention, or if got an intervention, had it somewhere else. We recognize that venous leg ulcer patients need, on average, an extra 0.37 ablation procedures versus non-ulcer patients to a statistically significant level. So when these patients have an ulcer, not only are they the most needy, and I think we'd all agree with that, they tend to need more care because it's gone on too long. So this is an image of a gentleman that's got post-thrombotic syndrome. He had seen just 2 weeks ago, we saw him. He had a non-typical ulcer. He's got no superficial reflux. He does have reflux and residual obstruction in his femoral and popliteal vessels. He was having intractable pain. We put him in an Uniboot. He's now in a Velcro device, and we saw him last week. This isn't that, but his ulcer's nearly closed just with compression. So it's very possible some of these patients are post-thrombotic. But we had 3,582 unique patients treated with ablation, and maybe our query was wrong. Okay, we had to have an ultrasound tied to that NPI. and we had to have a ICD-10 of a venous leg ulcer tied to that NPI, and then an ablation by that same provider in 2017. But that was our intervention rate. I want to do a little bit of math on Medicare beneficiaries. I Googled the number of estimated Medicare beneficiaries, so if it's wrong, I'm going to blame Google. But 44 million is what was reported. If we assume these assumptions, okay, these patients are older, if we assumed a 45 incidence of venous disorders because of the age, I thought that was reasonable. You get 19.8 million patients with venous leg ulcers. If you then increase from 2% to 2.5, just a slight bump, but 2.5, you get 495,000 subjects with a venous leg ulcer. The total patients, we said in Improving Wisely, that had an ablation was merely 3,582. That means that merely 11,000 or 2% of those that had a venous leg ulcer ultimately went to a practice that could potentially do an underlying intervention to potentially help them. And when you look at the global picture, merely 0.7% of all CMS beneficiaries with venous leg ulcers received an ablation. Is anybody offended by this? Am I the only one that sees this as a problem? These are the most needy of patients that are not being sent to somebody like ourselves that can actually make a difference in these people's lives. I'm going to ask you all to help me shift the argument. I think we've talked a little too much about over-treatment for years, and I don't think we have to bring more focus to that because the payers know who's doing the over-treatment, and that's something that's already been seen. I'd like us to look at the under-treatment and look at what we can potentially do to change that. If you simply look at the providers over-treating that are over 2 standard deviations from the mean, it's only 110 providers. But when you look at the CMS beneficiaries that are being neglected, stuck in wound centers, relying on that 30% per year recurrence risk, or those that go to a vein specialist, but they only do one thing, and that's a single ablation. They can't do phlebectomy, they don't do foam, and in all honesty, if you're seeing ulcer patients and don't do foam, I would encourage you to learn how to use it because that's the only way you can provide complete treatment. It's about under-treatment more than it is about over-treatment. We need to build more benchmarks, but we've got 3 consistent studies. So those are the ones that talk about intervention rate. But what we do need for benchmarks, there's an article coming out with appropriate use criteria I would ask all of us to embrace. It's not perfect. I think it's helpful. And I think it's something that we can certainly begin to incorporate as providers in this space. There may be a question of the role of perforator ablation. I think that is something, if there's anything controversial about managing reflux, I think we could have a whole day about perforator ablation, where the science is, or better yet, the quality science might be a single abstract. And then we also need more guidelines. I think you all know that we're working on completing that C2 CVI guideline, an update, if you will, on the guidelines, and you'll be seeing pelvic vein and iliac stent guidelines. The key to guidelines is they need to be multi-societal. They cannot be from a single society to carry weight. And I think you're seeing initiatives that are definitely multi-societal, where we're not just endorsing something, but we're active in the process of building it. And lastly, when you think about the providers in our space and the fact that we come from many different backgrounds, we need to do a better job of identifying the qualifications and standards of the vein care specialist. Many of us are ABVLM diplomats because it became our home from another specialty. It was a way that we could show a standard of which we've attained a certain degree of knowledge that says we're competent in managing venous and lymphatic disorders. The question might be, do we need something additional? Do we need something that couples ultrasound credential with it? That we don't know. But I think it's time that we start thinking about identifying what a provider in our society and a provider that's maybe not in our society but is out there treating veins, what level we want them to attain in order to believe that they're in a quality center or that they're competent to do what they're doing. So benchmarks are still important, but I want us to shift to those other avenues. We need to assure access to care and make sure we've got an adequate provider pool. Again, numbers, but different assumptions here. The graph that you see on the right was the Improving Wisely scope of all the providers, the 6,000 plus providers. And if you took the population of leg ulcers and you divided by that number of providers, it would end up with 327 venous leg ulcer patients per provider in 2017. Well, if you missed this, Healogics is a company that has 650 wound centers, many hospital-based, over 4,000 providers. They have started to bring vein ablation services to wound centers. Steve, I know you've been working with them, helping bring them up to speed. We've had some discussions with their medical director. It's not easy, getting people up to speed. But at least when you think about this, if we were to increase the pool from 6,000 to 10,000, that still would give us an opportunity to make an impact in these patients if they could all get access to care. That'd simply be 200 patients per provider to make an impact in these patients and change the narrative. With a potential increasing pool of providers for the right reason, you have to think about how can these providers get more tools in their toolbox. In this claims-based study, intervention rate was 45%, but they identified people that had an ablation. They still developed a new venous leg ulcer 0.8% of the time at 8 weeks and nearly 2% at 12 months. They also showed that if the patients received sclerotherapy, they had the lowest incidence of a new leg ulcer. We know patients that have had an ablation, they've had a leg ulcer, they had an ablation, they don't ever get closure of that ulcer because they've never had complete treatment. If you don't get them in compression, you don't continue to hammer on that reflux, these patients will either have recurrence early or they just won't heal. So we need to be proactive in making sure that there's adequate education for these folks so that they can get more competent in things like foam sclerotherapy. Payer perceptions must change. We've got level 1 evidence, and payers know that wound care is an expensive business, okay? When you can show that there are ways that we can help trim costs, and this is an article that showed that we've got a certain cost benefit of doing these treatments, this is also a part of every discussion we have with payers. And we need to continue to build on the relationships we've made this year because we need to make sure that appropriate care and access to care is made for these C6 patients. I would challenge us all to look at accepted guidelines and make sure that we're all practicing within guidelines. If there's an issue that falls outside the guidelines, then I'd say let's address it. But I think there are ways that we can provide cost-effective care for these patients and make sure that we're not ourselves from this society being the outliers. And I think everybody needs to be aware that carriers are worried about the concern of double dipping. And so just put that in the back of your brain when you're thinking about trying to treat the proximal great saphenous with one thing and then using another expensive technology below. I'm not so sure that's going to be something that's going to be permitted down the road. I believe collectively we can make a difference. There's no reason these patients with leg ulcers should have to wait 12 months, 6 months, or even 3 months to see any of us. This number, if we all had 200 a year, I think we could accommodate the entire venous leg ulcer population. I think we could actually make a difference in how these patients' quality of lives are and certainly improve the healing rates. We need to shift the argument, be an advocate for a limb emergency for leg ulcers. If you're not familiar with the EVRA article, we're going to make this available on our website and or at least a summary. We believe society should drive payer standards, but we're going to use data to shape policy. We need to continue to build alliances, and that's among societies, and then also build alliance with payers. I think we've made a lot of progress over the last year, and we're looking forward to growing that further so that we can actually be on the same side of managing these patients. And lastly, I've got a challenge for you. Grassroots works in anything if your heart's in it. We've got thousands of providers in our society. What would it be if every office took one ulcer patient and actually whether it's Facebook, whether it's a blog, whether it's LinkedIn, was able to show the patient journey for a patient with a leg ulcer and how they marched through treatment and got better. A buzz can be built, but unless we all do this together, unless we all do something to make a change and help bring awareness to this problem, it's not going to change. I would like us to be all thinking about how we can make an impact in these patients' lives, and I want you to be in the fight with us. I want to thank you for your time.